Hi, I'm Dr. Kimberly Turner, and welcome to Moms, Minds, and Medicine Inside Maternal Health Research. This podcast is your trusted companion on the pregnancy journey, where we break down the latest insights, answer the real questions, and empower you to make informed decisions every step of the way. Welcome to Moms, Minds, and Medicine Inside Maternal Health Research. I'm your host, Dr. Kimberly Turner, a semi-retired OBGYN physician, here today to talk about infertility. And your mind might say, what does infertility have to do with pregnancy? Well, there is some evidence that infertility, once a person is pregnant, puts your pregnancy at a little bit higher risk. So, to talk about that, we have a reproductive endocrinologist, Dr. Jerrine Morris, joining us, who works for Shady Grove Fertility in a busy practice, seeing lots of patients. So, welcome.
Hi, everyone. Thank you for that amazing introduction. My name is Jerrine Morris, and I'm a reproductive endocrinologist and infertility specialist. I work with Shady Grove Fertility, and I'm located in the Inner Harbor region of Maryland.
No, so you're not too far. We're in Baltimore right now as well.
Awesome.
Well, welcome again and thank you. I have been starting off every episode with just a little bit of background. Many people might not know what a reproductive endocrinologist is. Many people may not even know that OBGYN is a specialty and you're a subspecialist. Can you talk a little bit about what led you to this point in your career and what a reproductive endocrinologist is and does?
Absolutely. So I went to training for obstetrics and gynecology. For me, I was always drawn to treating women. I looked at maternal morbidity and mortality as being a driving force of getting me through medicine and wanting to combat that.
Mm,
From there, I saw a number of just differences in terms of how well individuals were able to build their families within the infertility space. I saw individuals who didn't have access to as many resources be less likely to conceive or a family build. I saw that people who, wanted to have additional children often waited at differential paces to proceed with an evaluation or an assessment. And so for me, I was really drawn to the patient aspect of infertility care. Once I started to pursue, thinking about this space, I found that the medicine behind it, some of which we'll discuss today, is particularly fascinating. So, a lot of the technologies in terms of reproductive health come from this space. A
mhm.
lot of the advancements, when you look at surgery, when you look at genetics, when you look at just medication management in general, are centralized within this particular subspecialty. The reproductive endocrinology component is centralized around just understanding female reproductive hormones, hormones that are made from the brain, hormones that are made in the ovaries, and how all these hormones impact the uterine anatomy. From there, infertility is really centralized on helping patients family build. If there is an issue with one's hormones, an issue with one's anatomy, or an issue with one's partner, which we see quite commonly as well. My job as an infertility doctor is to identify that issue and best help someone conceive. So although my journey has been long, I am so thankful I can practice this type of medicine.
And we're so thankful that you are interested in continuing this work. So, can you tell our viewers just what is infertility?
So, infertility means that when someone is attempting conception with a partner, so we have all of the organs present, uterus, ovaries, and sperm, and they are unable to achieve a live birth after 12 months of attempting pregnancy.
Okay.
That's the basic definition. In,
Great.
I believe it's 2023, ASRM expanded this definition to also include someone who needs an organ or a something that's missing in terms of gametes. If someone needs donor sperm to conceive, they are considered infertile. If someone needs donor
Mhm.
eggs to conceive, they are considered infertile. And if someone does not have a uterus, they are also considered infertile.
Oh, that's so interesting. What is ASRM for those who may not know?
ASRM is the American Society for Reproductive Medicine, and this is our governing body. These are the very brilliant change makers and policymakers in the field who often review the literature and make recommendations based on the literature so we can best, take care of our patients.
Okay. In reviewing this, because my clinical medicine years ended a couple of years ago, in reviewing this, I was reminded that the first in vitro baby occurred in 1978. And I don't know if you were alive then. I was.
What's that?
um, okay. Can you go over a little bit of the history? I know the advances are more than we can cover today, but the history of how that came about and what's happening now in this space.
Absolutely. In terms of high level overview, we notice that you can use hormones to manipulate how many eggs are released from the ovary. And by using hormones to manipulate this, ultimately increase or improve one's chance of having a child. Ovulation induction was really the forefront of this. So, using hormone medication to help with ovulation. From there, we noted that you can use a number of procedures to retrieve or remove eggs from the ovaries prior to ovulation to best help fertilization occur in the lab. And so when you look at IVF, it's hormone manipulation to start, and then finding a way to bring the eggs and the sperm together in an artificial situation, artificial scenario in the lab to create embryos. Finally, placing an embryo into someone's uterus really can bypass different anatomical challenges or distortions. And that's another aspect of IVF. Since 1978, a lot of things have changed. So we're not removing one egg at a time usually. We're a little bit more aggressive with the medication. So patients can ultimately have lots of eggs that develop. We're able to create multiple embryos in the lab, hopefully, if that's within the patient's capacity. We're now able to utilize genetics, so testing of embryos to identify either the healthier embryo in terms of number of chromosomes or eliminate some common conditions like sickle cell disease seen in the population. And uh, we're now able to freeze gametes, whether that's egg cells or sperm cells, but namely thinking about freezing egg cells with the purposes of reproducing, hopefully, in the future.
Great. So you did say IVF, just to
Mhm.
clarify for those that are not familiar with all of these acronyms. That's in vitro fertilization. And as you said, trying to get eggs out of a woman, biological woman, trying to get sperm and potentially putting them together and back into the uterus. Is that
Absolutely.
accurate?
That is accurate. The
Okay, good.
IVF is in vitro fertilization, or in vitro just means lab fertilization,
Okay.
that egg and sperm coming together in the lab. There are a number of procedures that we attempted in the past, putting egg cells and sperm cells together in the tube, or trying to manipulate the process so it's less laboratory based. But we do
Mhm.
find that with IVF as we know of now, taking eggs from someone with ovaries, taking sperm cells from someone with testes, putting them together in the lab and creating an embryo typically yields the highest chance of success.
Okay. Okay. So you also talked a little bit in your introduction about families that wait a little bit of time between children having
Mhm.
problems. That makes me think that maybe it's something to do with age. So is it the age of the mother? We're hearing a lot in the TikTok world about age of the father. My 26-year-old called me about is my age. Am I too old? What is happening right now? And he's 26, by the way, so he's not
Sick.
too old.
No.
What's happening right now with age, and what do women do if they're aging and they still want children? Or what do people do? Excuse me.
That's a great question, a loaded question, but a great question. Age is very impactful for human fertility. I start consults by addressing that. When you look back to the 1900s, 1950s, 1970s, we were not, as a human population, waiting as long to family build. You
Right.
saw families that were larger. You saw the age of having one's first child as being younger.
Right.
So, thinking about that contribution to infertility, that wasn't at the forefront of our minds.
Mm.
Now, as we have patients who are waiting longer for whatever reason to identify the ideal partner, to become career physicians like we are, etc., there are a number of reasons patients are not ready to family build. But keep in mind, biology still hasn't changed.
Mm-hmm.
To that extent, when you have an egg, uh, women, so individuals born with ovaries, born with eggs, have all the eggs they'll ever have throughout their lifetime at birth. The number decreases with time. The quality also decreases with time because those eggs have
Right.
been sitting there. And the way I like to think about it is, as you're getting older, yes, you are growing more wisdom, but you're also more susceptible to other things, disorders like cancer, hypertension, etc. The eggs are no different. They are susceptible to genetic abnormalities. That means that when you release an egg per month, as we get older, you're more likely to release an egg that is unhealthy, that is not capable of being fertilized. When you think back to older generations, you're not seeing a lot of individuals who conceived for the first time in their 40s.
That's
You're
very
seeing
true.
people conceive a lot easier in their 20s.
Yes.
So, the definition of infertility, while there is a blanket definition, and I'm sure we'll discuss this a little later, there's a time frame for which you can try to conceive. And if you're unsuccessful, you should present for an evaluation. And this is denoted based on age.
Okay.
If you're under 35, you can wait till up to a year, as I mentioned. If you're 35 and older, however, the recommendation is to undergo an assessment for infertility at 6 months. And that's
Right.
because we recognize the impact of aging on egg health and egg quality and how challenging it can be to combat that aging.
Yes.
Okay.
And what is the age for men? Is there such an age?
Ah, I love that question. So men are a little different. They're constantly producing sperm cells throughout the course of their lifetime. And so it's not uncommon to hear someone in their 70s, especially when you
Mhm.
look at entertainment industry, someone in their 70s having a child for the first time. Now, admittedly, you don't know the details. So once again, a
Right.
salt. But it is easier for men to conceive at older ages. With that said, we're now realizing paternal age can be impactful as well. That's
Okay.
starting at the age of 40.
Mhm.
We are seeing poor sperm quality, a higher risk of different neurodevelopmental disorders and things like autism, schizophrenia, and
Okay.
that is similarly linked to paternal age.
So we talked about what infertility is. What causes it? Besides age, what causes it?
That's a great question. So, when we think about causes of infertility, there are so many causes. It's hard to really, narrow down a list, but I always like to think about the organ system. So, you
Okay.
have eggs. Whether or not you're releasing eggs, that's a cause of infertility. It's ovulation disorders.
Okay.
We talked about egg quality being linked to eggs, and that is a cause of infertility. So, as we get older, it's more challenging. Ovarian reserve can be linked to infertility, particularly if the egg count is low. We don't ordinarily say diminished reserve in itself as a cause of infertility, but if the egg count is so low that you're skipping menstrual cycles, that is now a cause of your ovulation related infertility. Then, if I move on to looking at the uterus, if you have large fibroids in the lining of the uterus, a large endometrial polyp, something in the uterine cavity that could prevent implantation, that would be a cause. When we
Okay.
look at the fallopian tubes, if they're blocked, that is going to prevent the sperm and the egg from meeting. So, that is another cause of infertility.
Okay.
Finally, on the male end, when we think about sperm cells, if someone has something like a varicocele, which is blood that's pooling in the testicle, that can decrease sperm quality. It can decrease the concentration, the motility, and be a cause of infertility.
Okay.
Now, more broadly, conditions that can affect both men and women are genetics. And so I always ask patients what did your parents go through? Did they say it was really tough to get pregnant with you? Did they
Sure.
experience recurrent losses before they had you? Then we start to think about, is there a genetic underpinning to why the couple's not getting pregnant?
Okay. And how
Find
do you test for that? Oh, I'm sorry.
Yeah,
Continue
yeah.
with your
So
thought.
I'll continue with thought, and then I'll answer how to test for genetic related conditions. But finally, it has to be underscored the importance of different lifestyle factors and their contribution, I should say, to infertility. So if I have someone who's engaging in lots of tobacco use, alcohol use, tobacco
Mm,
also including vaping, if I have
mhm.
someone using illicit substances, marijuana use, even if approved with a marijuana card, all of these factors can contribute both to female and male infertility. I don't
Okay.
usually describe it as that's the sole cause
Sure.
because, yes, we do see patients who engage who are able to conceive, but that is not helping. And so those are both factors that can contribute as well. To
Okay.
answer your question about genetics, I genetics is tough because there are genetic conditions that we can test for through a blood test. Some of these tests will test for the number of chromosomes. Some will
Right.
test for the shape of the chromosome. But a
Okay.
lot of things that are genetic are just not discovered yet. They're not well known. And so if you have a strong family history, but we don't have a blood test that picks up on your condition, it still can be something genetic, just not necessarily something that we have a clear genetic, test for at that time.
Okay.
Mm.
So if I'm 30 years old, who I'm not. If I was 30 or when I was 30 years old, if I was having a problem and I was in a heterosexual partnered relationship, who should I see first? Should I go see my primary care doctor? Should I go see you right away? And at what age or what conditions does that change?
That's a great question. I would say at 30, it's reasonable to follow with your OBGYN doctor or primary care doctor. I
Okay.
tend to rely on my OBGYN colleagues a lot because the evaluation for infertility is fairly standard. Whether you see me or your OBGYN, both of us can order the test, and oftentimes insurance may require you have a referral from your OBGYN to even see me as a subspecialist. So do keep that in mind in terms of covering the visit. If patients wanted to see me first without seeing their OBGYN, or if I've actually found a lot of my practice, patients don't have an OBGYN, you can
Oh, that's
also
terrible.
Yes. But I do find that, if you're otherwise young and healthy and you don't have an immediate need for any testing or PAP, et cetera, that's not uncommon for patients not to have an OBGYN or a PCP or primary care doctor. And so I'm comfortable seeing patients who haven't had an assessment at all. Between 35 to 39, it's reasonable to go with either, although you really want to make sure you're seeing a infertility specialist or at least undergoing the assessment after 6 months of attempting. At the age of 40, because treatment success rates do tend to decrease quite dramatically, it wouldn't be uncommon and it would probably be encouraged to consider seeing a endocrinology specialist like myself at the outset. Some patients, even after only 3 months of trying to conceive, will undergo an assessment with an infertility doctor instead of waiting the full 6 months or instead of seeing an OBGYN.
Got it. Is there anything special that you counsel couples to do when they're trying to conceive in terms of timing? And we talked a little bit about abstaining from alcohol, tobacco, that type of thing. Anything else?
That's such a great question. I am a minimalist. I usually counsel on regular intercourse.
Okay.
And we are, as you mentioned earlier, in the era of TikTok and all these things where you're getting a lot of information from social media, which a lot of it can be accurate. It's just, it's very nuanced. Getting pregnant or trying to get pregnant can be challenging. It can be stressful. And so I
Hmm.
don't tend to recommend doing much else than having regular intercourse. And by regular, I mean every 3 days
Okay.
try to have intercourse. To add a little bit more nuance to it, there are a few things you can consider. One is
Okay.
at minimum tracking your cycles. This way, you have a better idea of how frequently you're getting the onset of menses. Are you
Mm.
noticing any other symptoms along with it? Lots of pain, heavy bleeding, presence of clots. Are you noticing spotting before period, prolonged spotting afterwards, spotting after intercourse? These are
Okay.
things that, if you don't conceive, will be helpful for a clinician in terms of thinking about you as an individual and why you're not getting pregnant.
Right.
I also will recommend looking at an app if you have it and looking at that fertile window and then looking at when your predicted menses should occur next. If the app is able to predict that, then that tells me that the fertile window that they're anticipating is probably correct. And so if you can't have intercourse every 3 days, then trying to maximize it during that predicted window, as long as the app has shown pretty good predictions in the past, is helpful.
Okay. I think,
Finally, for couples that have shift work where they don't see each other as frequently and it can be really
mm,
challenging to have regular intercourse, I recommend ovulation predictor kits. There's no one kit that's the best, but you can use a kit to optimize when you're having intercourse if you're only able to have limited attempts.
okay. Okay. Yeah. I used to think, especially in clinical, that once it got to really concentrating on those 5 days where you're
Yeah.
fertile, it
Mhm.
starts getting stressful even from then. So thank you for that. So we've
Absolutely.
talked about the definition, the causes. What about the incidence? How common is this? Seems like everybody's pregnant sometimes. How
Fair.
common is infertility?
I would say infertility is quite common in the general population. You're looking at about 12%. But I think the challenge with that definition is when you look at the 1 in 8 couples, it's not taking into account age. It's certainly going to be more
Okay.
common if you're older. And so if I have someone who's coming to me in their 40s, I'm going to say most patients in their 40s who are trying to conceive are going to have difficulty as compared to someone who's in their early to mid 20s.
Okay. That's a staggering thing, and I often found that was really difficult to discuss because people that are 40 are still young. Many of them are still quite healthy, having regular periods, and they don't understand how what you've already explained about the eggs and the quality of the eggs. So what happens if I do conceive at 40? Is that more dangerous?
It's a great question. And the long and short of it is yes and no. In
Okay.
terms of conception, as we get older, there are different conditions that are just more prevalent. Preeclampsia, which is high blood pressure in pregnancy, diabetes in pregnancy, preterm delivery. These are all more common in individuals who are older and they conceive.
Sure.
But also, we have to keep in mind that as we age, there are other comorbidities that we're just more likely to have had, which
Mhm.
then will impact your risk of more adverse outcomes in pregnancy. So while
Right.
you may feel great, you may feel that you're at your youngest, you may feel like you're still 20, your body probably isn't feeling the same. When you think about your blood vessels, when you think about, insulin sensitivity and how, food is processed, you are not the
Mhm.
same as you were at 20, at 40. And that is definitely going to be reflected in terms of obstetric complications.
Right.
Fortunately, I think the ACOG, which is, our Congress in terms of obstetricians and gynecologists and their guidance on pregnancy, they are very clear that at 35, you should start initiating additional testing during pregnancy to make sure that if you are at risk for any of these conditions, that they're being identified and being treated appropriately.
Sure. Anything to wrap up our first part of this that's a take home message? I know that I've learned that 40 is advanced paternal age. That was maybe not the case when I was still practicing. What else do we want to drive home to the viewers?
Yeah, the big thing that I want to drive home is infertility is a disease. This is a medical condition, not dissimilar to high blood pressure, not dissimilar to cancer.
Right.
It is stressful to be infertile. Anyone who is attempting pregnancy and is unsuccessful should undergo an assessment from someone.
Okay.
So, who you feel comfortable with is not as important as that you go to someone and be heard regarding the fact that you have proceeded along this journey and has been unsuccessful. Okay.
Okay.
I think that the older we get, it gets more challenging. And so, as you have been trying to conceive and you're of an older age, 35 plus, make sure that you're being thoughtful about seeking this evaluation sooner. Finally, if there's anything in your history that you know is unique, something about your periods being painful, being told that you have fibroids, having
Mhm.
irregular cycles, being told you had PCOS, if there's anything about you that is unique or different or that you've been told in the past, consider undergoing this assessment sooner.
Okay. So we're going to talk a little bit more about some of those conditions, particularly the
Mhm.
PCOS,
Mhm.
polycystic ovarian syndrome, at a later episode. So we're so grateful for your time and expertise, and you're making it plain for our viewers. So thank you so much, Dr. Morris.
Absolutely. Thank you for having me.